بسم الله الرحمن الرحيم. Dear Dr. Wael, Dr. Abir, dear colleagues, I have a pleasure to share in this scientific meeting titled Screening in Hepatology. Our subject will be screening for patients with NAFLD and NASH. To know the magnitude of the problem, this is at first the agenda. In short, epidemiology, types, and the clinical practice guidelines, and the answers in short for 4 questions. When to screen, who screens, and how to screen. And finally, the screening strategy adopted. As you can see, 1/4 of the global population are having NAFLD, non-alcoholic fatty liver disease, and actually it is considered one part of the metabolic syndrome. You can see here the numbers in millions in the United States, in 5 European countries, and here in China, 211 million patients with NAFLD. NAFLD come on the top of the list, in the waiting list for liver transplantation, according to the United Network for Organ Sharing. You can see how much is the magnitude of the problem. These are the 3 types of NAFLD: steatosis, simple steatosis, NASH with inflammation, and NASH associated fibrosis and cirrhosis. Rapidly in going to the morphological lesions, simply the steatosis or NAFLD only comprises the accumulation of fat droplets in more than 5% of the hepatocytes. While in NASH, there are 3 cardinal features according to the histopathology. These are the 3 cardinal features for the diagnosis of NASH: fatty change of the hepatocytes, hepatocellular ballooning, and lobular inflammation. Regarding this characteristic feature, which is the ballooning, it comprises rounding of the cytoplasm, and loss of the cytoskeleton of the hepatocytes with the presence of inclusion. What's the significance of this? This is pivotal and fundamental for the diagnosis of NASH, the presence of this characteristic feature. Remember, ballooning of the hepatocytes. This would progress to the activation of a network, meaning macrophage, B cells, T cells, killer cells, which would control the function of the hepatic stellate cells, and these hepatic stellate cells would deposit an extracellular matrix containing collagen, which would organize into fibrous tissue. This fibrous tissue would extend from the central zones to the periphery, what is termed bridging fibrosis. Due to the extension of this fibrous septa from the central region to the periportal region, there is loss of the architecture of the liver, which is the hallmark of cirrhosis. Now, the diagnosis of NASH would depend on the histopathology, especially the presence of ballooning of the hepatocytes. And the evaluation of the fibrosis stage is even more fundamental than scoring the necroinflammation or diagnosing NASH. And we have recent advances in the non-invasive methods for the diagnosis of liver fibrosis. This is a general principles for screening. It has been postulated in 1968 by Professor Wilson and Jugner and published by the WHO, اللي هو إنه يبقى فيه significant burden of the disease in the population, knowledge of the etiology and the stages, reaching a diagnosis by a simple and acceptable technique to the patient, and the available facilities, and finally the cost effectiveness. The ultimate goal of the screening is to identify patients at risk. These are the NAFLD clinical practice guidelines according to the ACLD, EASL, and the ABASL. And what we are dealing with is the screening where the 3 societies agreed that systematic screening of the general population is not recommended. in the American view, no screening is recommended due to the lack of the evidence-based of the cost effectiveness to support any screening program. While in the European view, they recommend the screening for diabetic patients, patients with metabolic syndrome, and patients with elevated liver enzymes. Going with this, the ABASL, who consider screening in patients with obesity and type 2 diabetes. These are the differences and the similarities between the clinical practice guidelines. Okay, screening, when to screen? The recent advances in the non-invasive methods to diagnose hepatic fibrosis allowed us to justify NAFLD screening more than in the past. And the cost effectiveness, for example, of transient elastography compared to liver biopsy has been studied and found to be a high quality cost effectiveness. Similarly, a Canadian study by the Ministry of Health in Ontario reached to the same conclusion. And in the United States, for example, screening for NASH decreased the number of patients who develop complications, morbidity, and mortality from liver disease by 12%. Who to screen? مين اللي هنعمل له screening? Number one, patients with risk factors for elevated liver stiffness, including obesity, metabolic syndrome, type 2 diabetes mellitus, elevated transaminases, old age, and male patients. In addition, several diseases are linked to NAFLD: coronary heart disease, polycystic ovary syndrome, sleep apnea, hypothyroidism, depression, and psoriasis. That regarding who to screen. طيب. Who screens? مين اللي يقوم بالمهمة دي? This would be influenced by the care structure in each country and the availability of the liver stiffness determining procedures. Usually, the primary care physicians أو الممارس العام is the first station for all patients. In Europe, screening algorithms were implemented in a total of only 5 countries: Belgium, Denmark, Czech Republic, Slovakia, and the United Kingdom, where the primary care physicians takes the responsibility of being a filter before referring all patients to the hepatologist. And that's why the education and training of the primary care physicians is essential. هنا دي المصفى primary care بيحدد low risk ولا intermediate or high risk وبعدين referral to the specialist. How to screen? These are the modalities of screening: ultrasonography, non-invasive elastography, MRI and CT, and laboratory chemistry score. Abdominal sonography has the advantage of being available, free of radiation, and there is no cost, but it has the disadvantage of being not sensitive in detecting steatosis below 10%, and also unreliable for detection of fibrosis or even staging of this fibrosis. A non-invasive measurement of hepatic steatosis by elastography هو بيستخدم shear wave ultrasound, where we have several generations of this. This is the FibroScan, which can also measure the fat content of the liver through the CAP or the controlled attenuation parameter. This is the RV by Siemens. This is the ElastQ by Philips. And this is the supersonic shear wave elastography by Eric's Roller. Transient elastography has a sensitivity up to 92%. Several difficulties are there, including the patients who are overweight, where we can use the XL probe instead of the usual traditional M probe. And as well, there is overestimation of fibrosis in extremely obese patients with BMI over than 47. MRI and CT can be used. However, the CT with exposure to radiation carrying a sensitivity of 46 to 72% only. Quantification of fat by the MRI can be used. However, it's used in research studies only. CT and MRI should not be used as screening due to the availability, cost, and exposure to radiation. Laboratory chemistry score، في عندنا سكورز للستياتوزيس وفي عندنا سكورز للفايبروزيس. السكورز دي عباره عن فيجرز من ال ALT، AST، age، platelet and etc. وبتتحط على certain location في ابلكيشن بيتنزل على الموبايل او بيتنزل على الكمبيوتر، وهو اللي بيدي الداتا على طول. طبعا ادفانتج اكتر حاجه بتستعمل الفيب 4 والنافلد فايبروزز سكور، وفي سيفرال ادفانتج للفيب 4 عن النافلد فايبروزز سكور، وهو سهل في استعماله. السكريننج استراتيجي دي احدث حاجه في سبتمبر 2021. ديتريش ايتال بروبوزد عمل الجوريزم لطيف جدا مبني على الايزل واليوروبيان اسوشيشن فور ستادي اوف دايابيتس واليوروبيان اسوشيشن فور ستادي اوف اوبيزيتي، ومناسب للبرايمري كير فيزيشن وكوست افكتيف. بيقول نحسب الفيب 4 ونحسب النافلد فايبروز سكور ونقسم البيشنتس الى لو ريسك، intermediate risk and high risk، واكوردنجلي نتصرف، بمعنى ان اللو ريسك يبقى فور فولو اب، الانترميديت والهاي ريسك يتعمل لهم الاستوجرافي، وممكن بعد كده يبقى ليفر بايوبسي. ده اللي كنا عايزين نقوله. البريفالنس بتاع النافلد is increasing، وانه reliable identification by non-invasive tools is available، وان السكريننج مهم جدا للهاي ريسك patients، والالجوريزم should be adapted لكل country according للفاسيلتيز اللي موجوده، وزياده الاويرنس للبرايمري كير physicians بالنافلد ومشاكله is very important. Thank you very much.